scare to some extent. So for this, we have one speaker at present. So I think we should start the session. Otherwise, it gets unnecessarily delayed. So I would like to invite Dr. Sucheta Pareja for her topic, Approach to Optic Disc Edema, Diagnostic Pulse.
Uh, and Thank you, the organizer, for giving me to talk on approach to disc edema, diagnostic pulse. I have no financial interest in this presentation. So as we all know, if there is an injury to the optic nerve, either it swells up or there is a pallor. So this optic disc swelling is usually a manifestation of a broad range of processes which affects the optic nerve head and the anterior segment of the optic nerve, and it can manifest the fundus picture. You can have a variety of fundus picture. So to clinching on the diagnosis, you have to be very careful and meticulous in taking the history, the clinical examination, and as well as correlating with other systemic examination and looking at the fundus picture. Also taking the help of other imaging modalities. So we'll just go by some case presentations. So my first case is a 22-year-old female with complaints of headache, intermittent blurring of vision for 3 months, no associated complaints, no systemic illness. But she was giving a history that she was gaining weight since last 6 months, and when she presented to us, she was around 80 kg. Examination, visual acuity was 6/9, no RAPD, and this is how her disc looked like. So looking at this picture, we just went ahead to do her visual fields, and we could find there is an enlarged blind spot. We asked for a neuroimaging, which came out to be normal. Had a neurologist consultation, did a lumbar puncture with CSF pressure coming to be 48 of H2O, and then, well, we clinched a diagnosis that it is a idiopathic intracranial hypertension. She was managed with tablet Diamox. So I'm not focusing more on the management, I'm just telling how the approach and clinical things will be. So we are coming to the second case. This is again a 25-year-old female, again presenting with complaints of headache, diminution of vision since last 2 months. When she came to us, she had a CT with her, imaging, which is quite normal. But she was rapidly losing her vision in the left eye, and it was around 660 when she was presenting to us. There was a RAPD, and this is how the fundus picture looked with us. So since she had a CT with us, we asked for a MRI, and the MRI was almost normal in this patient. We again went further with the neurologist consultation. We did a MR venography, and what exactly you can see in T1 post contrast, there was a narrowing of the right transverse sinus, suggestive of hypoplasia of the right transverse sinus. Probing into her, she gave that she had irregular menstruation. Asking for an abdominal CT, you can see that she had polycystic ovaries, and she came out to be a case of a polycystic ovary syndrome, that is PSOC. And what is very important, if you have patients of IAH, as we know that 15 to 46% of this child bearing age group, they can have this, and then managing them also with a lifestyle care, and not only taking care of this IH is very, very important. So that is something which we have to look into when we have patients with this at the age of childbearing age group, and to look whether they are having this PCOS syndrome. Coming to my third case, this is a 12-year-old female presented with inward deviation of the right eye since 15 days, associated with headache and vomiting. And she had esotropia of 30-degree ET, and there was a restriction of abduction in the right eye. Visual acuity was 612, 6.9, normal reacting pupils, and this is how her fundus picture was. So naturally thinking that can be there a rise in the ICT, we advise for a neuroimaging. And if you look at this, the T2 axial, you can see there is a intense surrounding lesion in the pons area. Asked for a contrast and MRI, so there is an increase in choline, and she came out to be a case of a pontine glioblastoma, which has to be immediately taken to the neurosurgeons. So some of the cases are very life-threatening. What I we want to stretch is that most common cause of a bilateral optic disc edema can be a papilledema, but not all disc edemas are papilledema. And very important, what we have to classify is if there is an increase in the intracranial pressure due to any of these causes, then only we can say it as papilledema. So not all disc edemas you can say that it is papilledema. Coming to this fourth case, you can see this is a routine case. A patient came to us with no complaints, just a routine checkup, 6/6 vision, and this is how the fundus picture is looking like. If you look at the optic disc, this has some bumpy things, not splinter hemorrhages, not typical, very, this margins are still clear, but there is some blurring of the disc margin. We went ahead to do a B scan, which is there in the OPD you can do, and you can see the hyperintense thing. We did a intense OCT, and this is a clear cut of a optic disc drusen. So patients with swollen optic nerve head and normal visual function, this ODD is the most common diagnosis. So these are certain things we read on, what are the true disc edema signs. I'm not going into detail. Coming to my fifth case, this was a 42-year-old female with intermittent blurring of vision. She was a known hypertension, but on intermittent medication. And she came all of a sudden with just a loss of vision. She had a very diminution of vision, and then she's coming to us, and this is how the fundus picture is. We just did a blood examination and a BP examination, and this is how her blood pressure was. It's a case of a hypertensive retinopathy. Just finishing with this case, which is a very interesting case. This was a very young child, a 4-year child, coming to us with the puffiness of the eyes, and then with a 6th nerve palsy. When we did, we had a bilateral disc edema. Going further into a pediatric consultation, we did all the systemic examination, came out to be a nephrotic syndrome. Again, further, the patient was on treatment for nephrotic syndrome. Then there was a recurrence. Again, he came back with again a disc edema. And then we went on to do a MRI, and what we found, there was a dense central venous sinus thrombosis. So it's a very rare condition thing in this, and it can be a life-threatening, so which has to be taken into consideration. So unilateral, if you have a good vision, we know that it can be a pseudodisc edema. If you have a abnormal optic examination, these are like papillitis, we know, or CRVO or neuroretinitis can be the causes. We have different modalities with us now, autofluorescence or enhanced depth OCT, rule out papilledema, doing a MRI, MRV, and then if you have all this abnormal neuroimaging or a neuroimaging, you will be coming to click the diagnosis. So my take home message is all disc edema is not a papilledema, and detailed history taking, visual examination, neuroimaging, as well as multidisciplinary approach is very important for approaching this disc edemas. Thank you very much.
So that was a very nice presentation, Dr. Sucheta, and I think you can conclude it by saying that we need to go for neuroimaging in every patient with bilateral disc edema. But yes, if it tends to come out to be negative, we have to look for all the systemic factors as well.
Addition I want to do is, in certain cases, we have to rule out demyelinating disorders.
Yeah.
And for that, we may have to do visual evoked potential, VEP, which helps us in differentiating between the demyelinating disorders and rule out any other possible cause of optic neuritis because of multiple sclerosis.
Yeah, it was very less, so I wanted to focus
Yes.
on certain
But this is
cases.
also an important
But
investigation.
yeah, that is also in when we already know that demyelinating disease is there. You do a MRI, you have a diagnosis, you are clicking VP, and all further tests are always there where we can have a consultation with a neurologist and we work on it. So we do a VP in those cases.
Nice presentation.
Another interesting case was there of nephrotic syndrome.
Yeah.
Recurrent.
Yeah, that was a very interesting. Clicking the diagnosis was quite difficult, but we could save the patient because just thinking of nephrotic syndrome and just treating them was something when it came recurrent, why it was coming when it is already on treatment and all. So we were probed into the thing because any nephrotic syndrome just coming, we will not ask for a neuroimaging thing. So that was what, because BP was high initially, yes, nephrotic syndrome, it can be there and then treat it. But then again, why there was a recurrence, why there was a sixth nerve palsy in this cases, and then that deep vein thrombosis, and which is very rare, and that can be a life-threatening. So this was some reported thing. So there were other things also, but that sort of time I could not present much.
Okay, that's fine. Nice presentation.
That was taken up, no? So anti-glaucoma coagulants were given, and it was taken up by the pediatric neurologist. Yeah.
Thank you. Thank you.
So
for
the
your-
interesting thing, one more thing, the interesting thing here was that the child had nephrotic syndrome. So maybe the child would have been treated. It may be because of because of steroids, or it may be because of the high blood pressure the patient is having. So we have to go for neuroimaging because that only tells us whether it is because of these factors only.
Yeah, madam, but when patients come with this nephrotic syndromes, even they present with disc edema, initially they don't ask for a neuroimaging, mainly of the brain and all. Optic disc, yes, you saw there is a disc edema. You always think that there is a ICT, you can, but initially it came out to be normal. So that was the thing. Then recurrent, when he came for the second time, got admitted. So why it is, we probed into the thing. So the importance is we have to follow up these cases. Just treating them once and leaving it, saying that they have a normal neuroimaging with them is not the thing. That is what my stress is.
Yeah, so there can be multiple factors playing. So that's good. Thank you. So after this very nice presentation, may we have Dr. Sudipta with her presentation on visual outcome post pituitary tumor excision.
Yeah.
Good morning, everybody. Excuse me. नहीं आया. Upload preview room में.
Any other presenter is name, please?
So today I'm taking you through the visual outcome post-pituitary tumor excision. Now in neuro-ophthalmology, you always have to be in combination with your neurologist or a neurosurgeon so that the vision that is there in the patient is always restored. Because per se, as being an ophthalmologist, we can't do much about the brain. All we can do is a placebo treatment for such patients. Just taking you through the brief anatomy. As we all know, the pituitary gland is situated next to the cavernous sinus where all the cranial nerves are located, which aid to the ophthalmology thing. Coming back to the brief history of pituitary tumors, is one of the most benign tumor in the central nervous system. The incidence of pituitary adenoma varies from 3% to 25%, and it can be categorized into the functional, which leads to the hormonal disturbance, or the non-functional tumors which has no hormonal disturbances. Diagnosis: variable history depending on the functional status of the tumor, its size, and whether it has any mass effect. Most ophthalmologic complaints are secondary to the mass effect caused by the macroadenomas. Together, many of these symptoms form the so-called chiasmal syndrome, which applies to any compressive lesion of the chiasma. Now coming to the brief signs and symptoms, headache, we all know it could be related to some kind of neuro-ophthalmology complaint. Decreased vision. In decreased vision, it is usually loss of the peripheral vision, or it can be loss of depth perception. Coming to the loss of peripheral vision, it can be either unilateral or bilateral optic neuropathy. The visual acuity may or may not be involved in these cases, because usually the central island is usually spared. Coming to the loss of depth perception, which is stereopsis, some patients will complain of with complete bilateral hemianopsia, will complain of a complete loss of the depth perception, especially in patients who would try to cut their nails or do some near work. They will complain of the loss of depth perception. This has been termed as the post-fixational blindness, and it is caused by the two blind temporal hemifields overlapping during the convergence. Diplopia is one of the main important signs that is seen, symptoms that is seen. Parotic diplopia from oculomotor cranial nerves, example the third, fourth and the sixth paresis, from lateral extension of the tumors into the cavernous sinus, or a non-parotic diplopia as a result of the hemifield slide, result of the loss of physiologic linkage between the two functional hemifields. Diplopia may be present constantly or intermittently, which varies from patient to patient and depending on the kind of the pituitary tumor that is present. Visual field defects, as we are all aware, tumor compression on the optic nerve or chiasma leading to axonal damage. The severity and the symmetry of the visual field defect may vary from patient to patient. So coming to the brief various visual field defects that we usually come across, it could be either bitemporal hemianopsia, which is the most common, cecocentral scotoma, homonymous hemianopsia, junctional scotoma, or monoocular visual field deficit of the junctional scotoma of the truncaire. Now, not coming into the description per se, and just to tell you about the compression side, in the first one it is usually in the optic chiasma region. The centrocecal scotoma is the compression of the macular fibers on the posterior of the chiasma. Homonymous hemianopsia is usually at the optic tract. Junctional scotoma is the ipsilateral optic nerve and the Wilbran's knee of chiasma, whereas the monoocular visual field defects is the ipsilateral optic nerve before the chiasma, before it enters into the chiasma. So, the other signs or symptoms that can be present, the patient may complain of pain in the face or sometimes including the sinus pain or ear pain. There could be a drooping eyelid. Seizures may or may not be present, and it may be associated with nausea or vomiting if the intracranial tension in the brain is increased. Optic atrophy is the last thing that we come across in these patients, where the patient is gone undetected of having a pituitary tumor in the brain or having a compressive effect in the brain that can lead to optic atrophy. So, the chronic tumor compression can lead to optic atrophy, and some of the atrophy is reported to be present in approximately 50% of the pituitary lesions with visual field defects, often described as the bow tie or band-shaped pattern in the both eyes. Visual field testing is very important in such patients. In fact, any patient reporting to you with a headache, you need to get a visual field testing done so that the initial picture of the brain or the any kind of neurological problem can be detected. Management, of course, comes into surgery. Pituitary adenoma can be either debulked or there could be partial excision depending on the discretion of the neurosurgeon as to which would be better for the patient, and is often carried out via the transfrontal or transsphenoidal or transterritorial approach. Endoscopic techniques have improved visualization of the tumor and allowed for smaller incisions and faster healing. Now, this is the most important slide, the predictive factors for post-operative visual outcome in pituitary tumors. A shorter duration of the symptoms before surgery can recover the vision completely. A younger age are associated with a higher amount of reserved nerve fiber layers. Additionally, large tumor size and supracell extension are significantly associated with poor post-operative visual outcome. And regarding the prognosis of the visual field, favorable outcomes are observed in patients with a short duration of symptoms, a higher pre-operative visual field, and a thicker peripapillary temporal retinal nerve fiber layer. Just skipping in, just a few of the images. As you can see, the pituitary tumors are lying there. These are the few of the visual field defects which was before surgery, and post surgery we can see a contrast in the visual field and improve in the vision. Thank you so much everybody for your patient hearing.
Anything you want to add?
Very nice presentation, Dr. Sudipta. So, one thing, because there may be variable presentation, and as you have told that earlier presentation can lead to better visual outcomes. So the visual fields, even if the patients present like with complaints in only one eye, the visual fields, the neurological should always be done for both the eyes, not to miss the subtle findings, like sometimes you find a supratemporal small area in the other eye, though the patient doesn't have anything there, any complaint in that eye. So neurological fields, bilateral, always in all the patients, irrespective of whether the patient is having any complaint in that eye or not.
Sometimes the visual fields gives us an incidental finding of a patient having a pituitary adenoma or a pituitary tumor in the brain. Thank you so much. Thank you. Absolutely. Absolutely. Sometimes patients go undetected. Even though they report to our hospital, there are no proper signs or symptoms. Sometimes subtle.
Study on it, and you do a OCT that gives you a substyle thing, the temporal goes early in those cases. So that also, suppose your visual field you are not able to do, OCT everyone has it and can do it, that gives you also a click. So, but what I wanted to say, that the vision recovery, if you see that the OCT findings are very early in these cases, and it is correlating with your visual field, and the earlier you are taking up,
Correct.
yes, the visual prognosis is good, but
Yes,
you
if it
see,
is delayed, yes.
because some of the patients come with a visual acuity of say hand movement, you cannot do a visual field in those cases.
Absolutely.
So the thing is, it's not that they don't recover. You have to follow these cases for 2 years, then only you can say. Because 6 months, if you do post-surgery and you follow them up, some recovery is still there.
Some recovery is definitely
So that
there.
is the thing.
Actually,
and
in these
because-
cases, it's a long-term recovery for
yeah,
these patients.
so-
Usually, I prefer to give them some kind of neuroprotective drug in these patients, so that in case in a sort of brinzolamide or any kind of dorzolamide, just to make sure that the IOP fluctuation throughout the day, which we have diurnal variation, is kept under control. Because whatever may it be, the compression effect of the tumor is there, and along with that, the intraocular pressure that is also there. At least we can keep the intraocular pressure under control, and the fluctuations can be taken care of, and then probably follow up them in the longer period. Anyways, they will be coming to the neurosurgeons for follow-up. They are usually toppled into our OPD, and so the visual, we can see the recovery in the
So
visual
actually
fields.
the neurosurgeons has to be made aware, because
yes.
the thing is, they have to collaborate, they have to send the patients. Any pituitary adenoma, if you don't follow up them for 2 years, actually you cannot predict what exactly are the poor
outcome
diagnosed
is.
outcomes for these cases. There is a recovery of the axonal flow that they are talking about, and more work is going on in it. So at present, actually, we are just talking on these things, we cannot still predict. So if you do a 6-month study or a thing, it's quite
does-
less. So that is the thing.
A longer period of study is definitely
Follow-up
required.
is also required, because we have to take care of any possibility of recurrence.
Yeah.
Because
Absolutely.
it's very important. Visual outcome has to be seen, visual field charting and perimetry has to be done regularly on a yearly basis, even for 2 to 3 years. But then another thing which is recommended by the neurosurgeons is also that there may be a recurrence, so that is also important to be considered.
In fact, in those half excisional tumors,
Yes.
in fact, in just those who are doing
There are some-
debulking,
yes.
they can come
They
back.
expect that there are some subclinical levels of tumor may be remaining, which may recur. So in that case, visual field charting is very important. It's very useful.
Just to be more specific, we are looking at the macular GCCs, that what you should look at where you get the nasal thinning, and that is exactly what you get on the visual pathway. So it's the pre-perimetric detection of your pituitary tumor. So when you have a bitemporal, you know there's already a functional defect. But if you want to pick up the structural, do the macular GCC, and if you notice nasal thinning in that, you know this patient is going to be prone, even if you have normal fields, in which case you can tell there is some amount of compression already on the pathways, so might as well go ahead with the surgery. So you can guide your neurosurgeons. But once your macular GCC is completely thinned out, then there is no sense following it up on that.
Correct. Thank you so much. Thank you.
Thank you.
Adenoma, they are followed up in endocrinology, and many a time, because when it is not more than 10 millimeter, they are not going to do anything, they are just following it up. So in that cases also, these early changes, they can be useful, because the perimetry, many a time they send the patient for the perimetry, the endocrinologist, or their pituitary macroadenoma or the microadenoma, whether it is increasing or not.
Okay, so earlier is always the better, be it the patient's presentation, the diagnosis, the treatment, and yes, the follow-ups, the importance cannot be underemphasized. Okay, so thank you for the nice presentation. Now, do we have Dr. Vikas Kanogia? Yes, okay. So we invite you for the next presentation, which is idiopathic intracranial hypertension.
So good morning everybody, and sorry I was just a little bit my topic is intracranial hypertension. So it was earlier known as VIH or pseudotumor cerebri, or there are other hydrops, meningocele hydrops, there were earlier names when it was discovered in 1800 something. So what is intracranial hypertension? It is a syndrome of increased intracranial pressure, and it can be primary. Primary means when we used to say BIH or benign intracranial hypertension, but nowadays benign is not used because many a time these patients progress to vision loss. So it is primary when there is no reason, and secondary when there are so many reasons to this. And what are the reasons? We would just look into it if the presentation goes by. And importantly, brain venography imaging have shown that the most patients with IIH may have structural abnormalities which were earlier considered to be IIH, primary IIH, of the cerebral venous sinus system. And stenosis of the transverse venous sinus, since IIH is often associated with venous sinus stenosis. Since the disease is often refractory, you start with Dimox and other drugs, and it is just continuously the papilledema is there, and gradually we know that the optic atrophy is now pursuing. So multimodal treatment are often employed, including the weight loss programs, carbonic anhydrase treatment, or therapeutic lumbar puncture and LP shunts. So despite these strategies, 38 to 45% of IH patients experience eventually symptoms of worsening or recurrence within 6 to 10 years. So CSF, it is a clear plasma-like fluid secreted by choroidal plexus and within the lateral third and fourth ventricle, and secretion of CSF equals its removal. That is how the ICP is maintained in the brain, and it is the quantity of it is 152 to 70 milliliters. So this is how the drainage of CSF goes through. It is there. So this is the choroid plexus in the body of the lateral ventricle. From there it goes to your intraventricular phenomena to your third ventricle. From there it goes to through cerebral aqueduct into the fourth ventricle, and from there fourth ventricle from your foramina of Luschka and Magendie to the cisterna magna and CP angle cistern. This is how, and from there the CP angle cistern, it goes into the spinal cord, again it goes up into the brain, and this is how it becomes circulated. So dural venous sinuses, these are the sinuses, they are lying between, these are the channels located intracranially between the two layers of the dura. That is the periosteal layer and the meningeal layer. As you can see over here, this is the periosteal layer and the meningeal layer. This is the periosteal layer and this is the meningeal layer, and this is the cross section of the straight sinus which is lying in between both the layers. And these are the arachnoid granulations, which are just what is they are doing, they are draining the CSF into the venous channel. Venous channel, that means your straight sinus, or you can say into the superior sagittal sinus. From there it is through your transverse sagittal sinus, through sigmoid sinus, and from there it is going into the inferior vena cava, internal jugular vein, and through the superior vena cava it is going into the heart again, and now it is again circulated. And this is a diagram showing how this raised ICP is the etiology of it and how this is causing the symptomatology. This is there can be an increased CSF production at the choroid plexus. There can be reduced drainage of CSF across arachnoid granulations, and this reduced drainage may be because of the arachnoiditis or tubercular meningitis or any meningitis, leptomeningitis, that is causing the decreased drainage through the arachnoid granulations. And there can be This all would be leading to your what? Increased venous sinus pressure. This increased venous sinus pressure can be because of this, the stenosis of these sinuses and mainly the transverse venous sinus. So just straight away I'm going to the case. A 50-year-old female presented with complaint of headache, tinnitus, decreased vision in both eyes for last 8 to 9 months. Best corrected visual acuity, both eyes 612. This was the fundus picture showing bilateral papilledema, and this was the constriction of the field, generalized constriction. This is your blue line showing that your RNFL on RNFL showing the optic disc edema, and this is the MRI of the case. Definitely you can see over here, this is a T2 weightage image, and over here you can see the partial empty sella or the empty sella. And over here you can see the perioptic sheets, they are dilated, again a T2 weighted image. And this is the MRV. Now this is, you can see over here, this is the MRV of this case. This is the superior sagittal sinus, this is the confluence of the sinus, and from here this is the transverse sinus, and this is the sigmoid sinus. So definitely you can finding it over here, focal definite stenosis over here, and this is the left transverse sinus which is hypoplastic. So this is hypoplastic, that means the whole of the drainage from this system, and over here this is a focal stenosis at the junction of the sigmoid sinus and the transverse sinus. So a diagnosis of intracranial hypertension was made. Patient was started on medical medications like acetazolamide, furosemide, oral anticoagulant. Headache was persisting and disturbing. Vision was 624. That has decreased from 612 to 624. Patient was having continuous visual deterioration. So DSA was thought of, and urgent stenting was thought of because of this. This is a DSA, you can see over here. This is the transverse sinus stenosis on DSA definite, and there was a pressure gradient between the distal part and the proximal part. It was more than 10 millimeter of mercury, and you can see over here. So this is how it was planned. You can see this is the balloon which was put into the transverse sinus, and after ballooning it, the stent was put. You can see over here, this is a meshed stent over there. So post stenting, you can see very well over here, this is now patent, the transverse sinus, the pressure gradient came down to be less than 10 millimeter of mercury. This was the pre-op picture, and this is the, on the right side is your post-op picture. This is how that papilledema resolved, but that your optic atrophy has ensued, and this is how that your RNFL decreased. Second case, 35-year-old female. She was a case, she came to us 6 years back, and she was having tinnitus, headache, and transient obscuration of vision. At that time, she was diagnosed as a case of primary IIH. She was put on acetazolamide, furosemide, and she went away to her native place. But after 6 years, she came to us. That means last December. She came to us. Then she was telling that okay, she was having a lumbar peritoneal shunt that was done in Bareilly by a neurosurgeon, but in spite of that, she was having transient obscuration of vision, and she was definitely having a tinnitus, which was very bothersome. That is the reason she came to us. She was off and on Diamox and your furosemide, and reappearance of papilledema was there when we saw her last year, and she was having this blurring of vision. This was her field, and this was her RNFL over here. You can see definitely it was raised. This was her MRV, a contrast enhanced MRV, and it was showing a definite focal stenosis. This was that your DSA, which was again confirming. This is the wire, the stent wire, you can see the guiding wire, sorry, and this was the pressure, the 42 millimeter in the proximal part and 10 millimeter in the distal part. That means it was 32 millimeter difference between both of these. So again, this is the mash of the stent, you can see, and this is pre and this is post. And definitely the very next day, that means within 10 to 12 hours, she was saying, okay, my tinnitus has gone. Gradually, she was improving with a transient obscuration of vision. So this is how that case. So this is our study, papilledema, revisiting after sinus angioplasty of chronic cerebral venous sinus thrombosis. And this is another study that was published in 2023 in Frontiers, transverse venous sinus stenting, reversing your medically refractory IIH or the secondary IIH, you can say. So what is a medical refractory? It is a progressive visual field loss on maximum, drug therapy, persisting papilledema on maximum, drug therapy, recurrent papilledema on weaning of drug therapy, or intolerance to your maximal drug therapy. So these are the adults which with medical refractory disease associated with significant transverse venous sinus stenosis. Such patients, historically they progress to CSF diversion with a shunt, or fenestration can be done, but maybe that your stenting can be a viable option in these cases if all the symptomatology is persisting. So I'm not going into these details. All patients with IIH should undergo MRI with contrast, definitely, and MRV with contrast. That is very much important, because without contrast, many a times these patients can be missed. And when medical treatment fails, visual loss is rapid, then lumbo LP shunt or optic nerve fenestration may be considered prior to your stenting. Stenting means that first you have to do the DSA. I think that is enough. Thank you.
Thank you, Dr. Vikas. We would request all the speakers to kindly adhere to the time limits. So, any questions or discussions? Okay, thank you, Dr. Vikas. So, we would like to invite Dr. Shruta Kirti for post-fever optic nerve disorders.
Good morning to one and all. So today I will be talking on post-fever optic nerve disorders. Post-fever optic neuropathy is a rarely reported entity in literature which is associated with a wide variety of infectious agents, and it develops few days to weeks post-infection. The mechanism is either a direct invasion by the pathogen or post-infectious disease, which is mostly an autoimmune mediated demyelination or inflammation of the optic nerve. The etiological classification includes viral, bacterial, parasitic, fungal, and post-vaccination. Coming specifically to each of these, first is the dengue-associated optic neuropathy, which is mostly bilateral. The incidence of optic neuritis is 0 to 1.5%, and many of these patients present with anemospectrum disorder. The mechanism is either a direct viral infection or immune-mediated or vascular, as well as degenerative or inflammatory reaction. Next is the varicella zoster associated optic neuropathies. Varicella zoster can cause both varicella zoster and herpes zoster and may lead to acute retinal necrosis syndrome as well as progressive outer retinal necrosis. The optic nerve involvement has been reported in 17 to 18% of eyes with progressive outer retinal necrosis, and the eyes with progressive outer retinal necrosis associated optic neuropathy have a poor visual outcome despite being treated aggressively with the antivirals. Another thing is the SJDO associated optic neuropathy, which can occur simultaneously to the acute vesicular rash or frequently as a post-herpetic complication. And there is good recovery with systemic acyclovir and corticosteroid therapy. Next is HSB associated optic neuropathy, and the pathogenesis could be either due to intraneural vasculitis, compressive ischemia of the optic nerve, inflammation, and necrosis due to direct HSB infection. The next is the chikungunya associated optic neuropathy, which could be either due to the direct viral mechanism or immune mediated reaction, and steroids accelerate the recovery if they are initiated earlier. Then is the HIV associated optic neuropathy, where there can be unilateral or bilateral clinical presentation, and the histopathological examination shows axonal degeneration along with demyelination, glial changes involving the vacuolated oligodendrocytes and mononuclear phagocytic cells, and mostly it is mediated by HIV-infected macrophages. Other viral fevers like influenza, cytomegalovirus, and COVID has also reported to be having viral fever associated optic neuropathies. Next, coming to the bacterial, the first is the typhoid associated optic neuropathy, where as per the paranoids and Skims theory of optic nerve changes, there can be cerebral congestion with serous effusion into the arachnoid cavity, lateral ventricles, and subarachnoid space. It may occur as an vasomotor disturbance or an autoimmune reaction, and the management is with systemic antibiotics along with systemic steroids or oral carbonic anhydrase inhibitors. Next is tuberculosis associated optic neuropathy. As we all know, the diagnosis of ocular TB is mostly presumptive. The various mechanisms which have been reported are a direct mycobacterial infection or a contiguous spread from the choroid, hematogenous dissemination, or a type 4 hypersensitivity reaction. CNS tuberculosis can also be associated with optic nerve involvement, like in patients with TB meningitis, optochiasmatic arachnoiditis, and tuberculoma. Unilateral disc edema can also be seen secondary to tuberculous posterior scleritis, as we all know. Similarly, in Lyme's disease also, there can be optic neuropathy mostly in the early and disseminated stages, and it is mostly bilateral with a bimodal distribution of the age. In children, there is papilledema associated with meningoencephalitis, whereas adults have a variable presentation with papillitis, ischemic optic neuropathy, optic atrophy, as well as chiasmal syndrome. In malaria-associated optic neuropathy, there is a rare presentation of either a retrobulbar neuritis or papillitis, and the pathogenesis is tissue hypoxia because of the parasite which causes damage of the optic nerve fibers. Another entity is post-vaccination fever and optic neuropathy, where the event occurs hours to weeks after the vaccination, and the presumed pathogenesis is immune-mediated mechanism, which is mostly bilateral. The clinical spectrum is either a papillitis or a retrobulbar neuritis or neuroretinitis, and corticosteroids when given earlier hasten the visual recovery. Coming to the pediatric versus adult cases, in the pediatric the presentation is mostly bilateral, whereas in the adults there is an unilateral presentation. The time elapsed is shorter in the pediatric group because of the fulminant immune response, whereas it is longer in the adults. The neurological manifestations are more common in the pediatric group as compared to the adults. The pediatric post-fever optic neuropathy is most commonly associated with acute disseminated encephalomyelitis, whereas adults have a more common association with multiple sclerosis and anemospectrum disorders. In the anatomical location, papillitis and papilledema are more common in the pediatric variety, whereas retrobulbar neuritis is most common in the adults. And there is a remarkable response to steroids in the pediatric group as compared to the adults. So I would like to highlight our experience at a multi-specialty hospital. We did a prospective interventional study of 1 year and included all the patients who attended the ophthalmology OPD and diagnosed as having optic nerve disorders with a history of fever within the last 1 month. There was a male preponderance in our study participants with a mean age of 23 plus minus 6.5 years. There were 7 children and 22 adults in our study participants. And the mean time which was elapsed between the fever and optic nerve involvement was found to be 2.53 plus minus 1.12 weeks. The most common etiology was dengue followed by Mycobacterium tuberculosis and typhoid. And in the fundus findings, papillitis and retrobulbar neuritis were more common. We did the OCT RNFL where RNFL edema and thickening was more common followed by RNFL thinning. In the neuroimaging findings on MRI brain and orbit with contrast along with MRV with contrast, unilateral followed by bilateral optic nerve hyperintensities with thickening and post-contrast enhancement were more common, followed by transverse myelitis and radiological signs of the raised intracranial tension. Serum NMO was positive in 45% of the study participants and MOG was positive in 23%. There was a significant improvement in the best corrected visual acuity in logMAR units at 3 and 6 months of follow-up after a proper treatment of the patients. So my tech clinic message would be, post-fever optic nerve disorders are a rare clinical entities with varied etiologies and presentation. The visual prognosis is affected by initial vision at presentation, the time interval which has elapsed between the vision loss and initiation of appropriate treatment, the severity of the neuroimaging findings, and of course the seropositivity, that is the NMO and MOG status of the patient. There is the need for multidisciplinary approach, and as always, an early referral by a treating physician helps to achieve a good visual outcome. Thank you.
Take clinic message is an interesting thing. Okay, nice presentation. The one thing we would like to discuss is, like in patients who present with optic neuropathy, I think we all differentiated majorly on the basis of whether the disc edema and optic neuritis, whether the vision is affected or not. If the vision is impaired, we take it on the side of optic neuritis, and if the vision is unaffected or less impaired, we go towards disc edema. So in children, like
actually, it's not only the vision but also the color vision, contrast and the status of the pupil, whether there is a RAPD or not. So these all factors will guide us whether it goes in the line of the optic neuritis or whether it goes in the line of the papilledema.
Yes.
Along with vision, these factors are also important, and also we do the fills, OCT and other things.
yes, definitely all these. But what I mean to ask here is that in pediatric patients, okay, like these patients I think would not be very much able to do rest of the tests. So there you have to mainly rely on your clinical findings.
Yeah, obviously.
Right? So like how do we go ahead with treatment in patients where we suspect it to be related to some infection? The optic neuropathy, the neuritis related to some infection. Do we directly start the steroids and or we wait for the investigations, or under the broad spectrum cover of some antibiotics we start the steroids straight ahead, particularly in the pediatric?
No, initially we don't start the steroids. So first of all, we will do all the investigations, and after a pediatric consultation, when all the investigations are done and then the diagnosis is confirmed, then only we can start steroids. But usually that happens, yeah. So actually we have to work in a collaborative manner, so that in that case then the patients will be benefited because they will be treated earlier. That's what I was
It
saying.
should be done like this, but is it the consensus we all do it by this?
As it was a
Of course, in
multi-specialty
cases of-
hospital, so there was a collaboration between all the departments. So we could treat the patients earlier because they were referred to us earlier. That's what happened in our.
In children, the prognosis is usually good.
Yes,
With the treatment, there's a very good visual outcome.
yes.
But in adults, there may be a compromise.
Yeah.
The one thing I saw in your presentation, you said that the time elapsed between the presentation of optic nerve disorder in an adult is about 22 weeks. So a detailed history is required. We have to correlate that 22 weeks back he had a fever or some.
No, it's not 22 weeks. I told the time elapsed is a little lesser in the pediatric group as compared to the children.
You said 7 weeks in children and adults, I think 22.
It's not like that.
Let me see it again.
Yeah.
Yes, because the time gap between the attack of fever and the presentation, it's also very important.
So the time elapsed is longer, but it's not because we have the
In one of your slides, it was like this, in which there was a pie chart was there.
Okay, our presentation.
And
No,
this
we
one.
told that, the time elapsed, the mean time was 2.53 plus minus 1.12 weeks. There were 7 children and 22 adults in our
22
study.
adults is a number,
Yeah,
okay.
that
I
is
thought it's the
number.
weeks.
No,
Okay,
no.
okay,
Because the criteria of post-fever optic neuropathy is
Yes.
like it should be within 4 to 6 weeks after the
Yes.
onset of fever. Otherwise, we
Yes.
cannot relate
we
it
cannot
to
relate
that
it, that's the
neuropathy.
point. Okay, it's okay, fine. It's okay.
Thank you.
Thank you.
Okay, so thank you. I invite Dr. Subha Prata for a presentation on evaluation of disc edema.
Good morning, everyone. And my topic is how to evaluate the disc edema. So we discussed a lot about specific causes for the disc edema and about their management and all. This is an overall approach how we'll look forward when we see a disc edema in our clinics. So all causes of active or passive edematous swelling is known as disc edema, but we describe or treat papilledema in a different category other than all types of disc edema. So papilledema is a hydrostatic, non-inflammatory, secondary to raised intracranial pressure for any region like maybe a space occupying lesion or hemorrhages or infections where intracranial pressure is dead, and it is always bilateral and may be asymmetric. So I have discussed all details for the papilledema. So I am going for disc edema itself. So disc edema, when we see hyperemia, blood disc margin, nerve fiber layer swelling, disc elevation, tortuous vessels over the disc and peripapillary hemorrhage, we call it as a disc edema. So when we say that this is disc edema, we must rule out pseudo disc edema also. So most important the pseudo disc edemas are optic nerve head drusen, more common, tilted disc, small hypermetropic disc, optic disc hypoplasia, and other things like morning glory syndrome, Buzzminster's papillae, myelinated nerve fibers are some of the causes of pseudo disc edema. So Buzzminster's papillae and morning glory, they are congenital. Buzzminster's papillae, usually they are asymptomatic with good vision, accidentally diagnosed, and morning glory are mostly, they are associated with some squint, low vision, nystagmus, like that. And medullateral nerve fiber, like any ophthalmologist can rule out, and optic nerve head drusen, many time they create us in confusion when the patients are referred from the neurology or obstetrics to comment on the disc edema. So two disc edema causes are mostly inflammatory, ocular hypertony for any reason, maybe trauma, maybe rupture or some post-surgery, vascular causes, orbital and infiltrative causes. So one thing is how to approach a disc edema. Patient has come to us with some symptoms, headache, vomiting, visual disturbances like that, or we are accidentally diagnosing disc edema on our routine clinical examination. Patient has come to us for some other reason, or patient is referred from any other department, physicians, neurology or obstetrics to look for the disc edema and comment on that. So we'll have to look for this is unilateral disc edema or a bilateral one. Gender and age is very important. As we discussed, idiopathic intracranial hypertension and papillitis, these are more commoner below 50, and anterior ischemic optic neuropathy more commoner after 50 in that way. So as I told you, with or without symptoms, is it a accidental detection of disc edema? If you are accidentally detecting a disc edema, then you must rule out pseudo disc edemas first, then before asking for other investigations. Then signs of ocular inflammation, like you are seeing in uveitis, is it a posterior uveitis, posterior scleritis, like that, or a VKS? We have to look for ocular inflammation in that also when we are seeing unilateral disc edemas mostly. Then we have to look for ophthalmologic and systemic proper examination, like patient is a diabetic or hypertensive, that also we will have to look for. Then comes the radiological examination. Once we clinically established partially that this is a true disc edema or a pseudo disc edema, this is unilateral or bilateral, then we can clinically point out that this may be this, and accordingly we should advise other radiological or further investigations. So as we discussed in our previous speakers, that most common symptoms are headache, vomiting, retroorbital pain that has more points towards the papillitis, then diplopia, vision loss or blurring, photophobia. These are the commoner symptoms if patient is symptomatic. And as we discussed common clinical IIH, my previous speaker discussed about idiopathic intracranial hypertension. This is very commoner in young females, and it is recurrent. Patient comes, even subsides edema, then after 2 years, 3 years also patient again presents. So we have discussed that very elaborately. Then papillitis, as it is a ocular emergency, papillitis amongst all the causes for disc edema, papillitis is the most ocular emergency. We have to treat it immediately with steroid pulse therapy. That is also more on younger age group. And AION is the commonest, anterior ischemic optic neuropathy, commonest for the older adults. Diabetic papillopathy, hypertension, CRVO, these are other causes with this thing. Then ocular examination we have already discussed, that is pupillary reflex, visual acuity are very, very important to rule out optic neuritis, AION, like that. And signs of inflammation we must look for. Color vision, these are there. And as we discussed a lot about OCT, this one, CT scan and MRI in brain, and perimetry, B-scan, OCT, these are very, very important tools and differentiating various disc edemas. So inflammatory, most common are papillitis, neuroretinitis and papillophlebitis. Vascular, CRVO is a dual pattern. CRVO itself can cause disc edema, and long-standing large disc edema can cause CRVO also. And diabetic papillopathy we saw very common, anterior ischemic optic neuropathy, hypertensive retinopathy, that is usually grade 4 hypertensive retinopathy with bilateral disc edema we see. Then orbital causes are there, tumor, orbital cellulitis that will cause disc edema and compression. So papillitis and optic disc drusen, if we do a OCT, we can see a true disc edema with optic nerve head drusen. We have also seen with our previous speakers. Then anterior ischemic optic neuropathy is very clean cut. If you only do a perimetry, that will tell you that this is a anterior ischemic optic neuropathy that will coincide with the superior disc edema with the inferior field defect. In that way, we can pinpointly diagnose that we are dealing with a anterior ischemic optic neuropathy. Then diabetes versus hypertension. In diabetic papillopathy are unilateral, not always bilateral. We may or may not find other retinopathy features. Even without retinopathy features also, they present with diabetic papillopathy. And hypersensitive retinopathy, what in my experience we always see with a grade 4 hypertensive retinopathy with malignant hypertension, maybe eclampsia patient also we see with that. And CRVO, as I told, this is a very clean cut picture where you see all features of CRVO. Then investigations, almost we have all discussed everything in details, so I am not going in detail again. Management is always finding the cause. First to find out it is a papillitis or papilledema or pseudodisc edema. Then history taking and detailed clinical examination is very, very important before ordering any other radiological investigations. And take home message I will give in my last slide, that we must diagnose papillitis clinically and start the treatment with pulse therapy, IV methylprednisolone to save the vision, even before establishing the exact etiology. If we kill our time by establishing the exact etiology for papillitis, we may lose the vision. So we must start treating the patient with IV pulse steroid. Then side by side we can establish the exact etiology for that. Thank you. Thank you.
elaborated the approach, like how to approach a patient with disc edema. First to rule out a pseudo disc edema, and once it is confirmed it is true disc edema, then how to go ahead with it. It was really nice presentation. Thank you. Do you have any questions?
Thanks. Thank you.
Nice presentation.
So do we have Dr. Meenakshi Dhar?
No.
I think she's not there. So, okay. So now, can we have Dr. Jyoti Matalia? Yeah. For her presentation on acquired nystagmus, evaluation and principles of management.
Yeah, so good morning, and I'm going to be talking primarily on acquired nystagmus and try to decode and how you should go about. So what is nystagmus? It's an involuntary rhythmic oscillations of the eye which have a fast component and a slow component. So you can see here the slow component is to the right and the fast to the left, and it is a fast component that helps us detect the direction of nystagmus. So let me take you through the classification. So basically this is physiological and non-physiological, but what I am going to talk to you is about acquired versus the congenital one. So how do you differentiate? So importantly, note the features. So you have you understand that acquired is purely sinusoidal. It's asymmetric compared to the congenital. Direction is omnidirectional, vertical, circular, elliptical, but in case of congenital it's horizontal, uniplanar, and rarely you get vertical or torsional. Remember, the OK and reversion is never in the acquired compared to that in congenital. And oscillopsia, where the patient believes that he is able to see the images moving, is frequent in cases of acquired. Now this is a very good classification. Those who want to know can look at this, the CMAS classification, for trying to find out the various nystagmus types. So I'm going to simplify the various types of acquired nystagmus into jerk and pendula, basically on the morphology. So let's look at the jerk, and I'll try to describe in terms of the vestibular peripheral and the vestibular central. So how do we go about? So vestibular, you can see, is unidirectional or multidirectional as the central cause, whereas the peripheral one is unidirectional towards the normal eye. You also look for the central and the peripheral signs related to the brainstem, and the other peripheral is related to the ear. And you should understand the central gets suppressed with visual function, visual fixation, but the peripheral does not get suppressed. And the specific signs that the brainstem or cerebral will be seen in the central, and the vertigo, hearing loss and tinnitus will be seen in the peripheral part. So let's try to differentiate these 6 etiologies and the 6 types of central vestibular nystagmus. So let's look at the downbeat and upbeat. So the upward drift followed by a corrective downward saccade is a downbeat nystagmus. Classically features are pontomedullary junction, and flocculus is the site. You should know the causes are Arnold-Chiari malformation, very common, where the cerebellar tonsils they slip down, and these are the various causes that come for downbeat nystagmus. Commonly MS and drugs is what you should have, so good history. This is a child who had a downbeat nystagmus. So you can see the eyes which are moving downwards. Now upbeat on the other hand has a fast phase beating in the upwards direction. Side being superior cerebellar peduncle and the pontomedullary or the pontomesencephalic junction. Again, these are the various causes, and you'll get the details in whenever you look in the Google and all. Now this is a classical child who had an upbeat nystagmus, but what you should understand in a child, the history of consanguinity, don't always jump to neurological. It's not always neurological. So we have found out a case of upbeat nystagmus with a cone dysfunction. So important history of consanguinity, and in a child eventually this upbeat becomes a horizontal. So try to study your nystagmus in children over time because it can change. Then is the seesaw, the hemi-seesaw. So intorsion and elevation of one eye and simultaneous extorsion and depression of the other eye is a classical seesaw, and this is the site where you normally see it. Important is paracellular tumors, so pituitary adenoma, craniopharyngioma is what you should look for. And infarcts or hemorrhages, trauma, congenital causes is what you should rule out. So this patient classically had a paracellular tumor and her classical seesaw nystagmus, as you can see. Then the periodic alternating nystagmus, horizontal nystagmus that predictably oscillates in direction, amplitude and frequency. So look at the nystagmus for 3 to 5 minutes. So you can see a right beating nystagmus. Eventually, if you keep on concentrating, becomes a left beating nystagmus. So this is very important. So watch the nystagmus. Don't jump to conclusion on the basis of just one looking at. 5 minutes is required. And these are the various causes, what you can see. And so in this patient, the left beating nystagmus, after some time you watch him, it goes into right beating. So this is how you pick up a periodic alternating nystagmus. Conversions retractions in nystagmus. is classically a nystagmus, which is a part of the dorsal midbrain syndrome with an upgaze palsy, defective conversions, eyelid retraction, and a light near dissociation. So you can notice he's trying to converge, he cannot lift his eye upwards, and there's some amount of retraction which is there. But if you see the horizontal movements are perfectly okay, there is no issues, but he's not able to converge or he's not able to lift the eyes up. So this is the classical feature. See, you try seeing the eyes are retracting when we are making him attempt to look up because he cannot look up. Side beam posterior commissure lesion, and these are the various causes of a convergence retraction nystagmus. And finally, the internuclear ophthalmoplegia. This is a dissociate disconjugate nystagmus with an eccentric gaze nystagmus, where you see that the left eye is not adducting, but the right eye has an abduction nystagmus, and the causes being brainstem infarct or MS. And this is what you can see a patient had it. So what is a quick summary for these kind of things when you have an abnormal eye movement and the possible lesion? So it's a dissociated nystagmus or INO, it's the MLF, medial longitudinal fasciculus. A downbeat nystagmus is cervicomedullary junction. Upbeat nystagmus is a posterior fossa. Seesaw nystagmus is paracellar. Monocular nystagmus of childhood is anterior visual pathway. Periodic alternating nystagmus is a posterior fossa, and convergence retraction nystagmus or a dorsal midbrain. So now let's quickly look through the pendular causes of acquired nystagmus. These are the various. Pendular is a sinusoidal movement. You don't have a fast component here, but somewhere the eyes are moving sinusoidally. These are the various etiology. Classically, the spasmus nutans, which is a triad of head turn, head nodding, and you can see the simmering reflex which is there, and it's in a child, which typically develops the first year of life and resolves by the 10 years, and you have to rule out a CNS glioma. Then you have the OPN or the oculopalatal myoclonus, which is a acquired nystagmus of contiguous and rhythmic movements of the soft palate, and therefore you should ask the patient to look at the palate. You can see the palate moving along with a vertical pendular nystagmus, and occurs after injuries of the brainstem or the cerebellar regions. Then the OMM or the oculomasticatory myorrhythmia. Here you can see it's a conversion diversion nystagmus. That means a disjunctive nystagmus, also called as PVOs, pendular versions, oscillations moving in opposite direction, are very, very pathognomic of Whipple syndrome. So when you have conditions like this, and the rest, as you said, acute brainstem strokes, you have central myelin, multiple sclerosis, so you need to take the history and find out what could be the cause to it. So when you have something like this, there are multiple treatment options, but always try to do it along with your neurologist, and it's all best. I have the advantage of being in a health city where I get a direct coordination with the neurologist, and you can plan the treatment. But ending by saying that if you need sometimes surgically also it's important, where you do large form muscle recessions of about 10 to 12 millimeters of the horizontal recti, so as to relieve them if you're not able to completely correct them by medications. And by ending that there are certain serious neurological diseases you should think when you see an asymmetric nystagmus, a monocular nystagmus, which is a visual pathway disorder, vertical nystagmus, and a purely torsional nystagmus, provided you have ruled out a congenital cause. So thank you very much for your patience.
Is there any difference between the head posture? You have not mentioned that.
Yeah, so these are acquired cases. So when you are talking about head posture, we're looking at specific congenital ones, which are there since birth. In acquired, when they come later, they are oscillopsia, and whichever direction they look, they would not have a specific head posture.
Nice presentation. It's really important for us to focus on the type of nystagmus in order to locate the point where the problem is. And in acquired, most of the causes is, I think, trauma and any drug induced.
Yes, very common. So basically important in any neuro-ophthalm is take history. You have to take very important. Sometimes it's difficult to even pick up that particular nystagmus, so take your videos, sit back, call the patient again, sit and study the nystagmus. You can study over time, so always take video photographs of them, and over time you'll understand that yes, this is what it is, I thought it was different. So take videos, take history, sit and think back. You can have a group and talk to them so that you really know what you're looking at, and always have a good collaboration with your neurologist so you know what you're thinking, what they are thinking, and then it helps us to build it up. Yeah, sure. Yes, acquired nystagmus definitely, yes. But that's what I'm telling you, need to really differentiate. Many a times a patient comes, he's not aware that there is nystagmus, and then you look at his old videos, then you remember that he's been having a head posture, there is something there, and it's not entirely congenital. But in doubt, always do it. It's always best to be there.
Yeah, so I think most of us develop the seesaw nystagmus on seeing a patient of nystagmus, but your very nice presentation and particularly the inclusion of very good videos, I think that would make that less evident.
Yeah, so we actually did these animations to make people understand, because in clinical it's difficult, but when you actually show it, then you know what you have to compare with. So that is.
So these were really nice. Yeah.
Okay.
Thank you for
Yeah,
the
thank you.
presentation. Okay. So our last speaker would be Dr. Chinmay. She would be talking on central eye movement disorders, internuclear and supranuclear.
Very good morning to all of you. Just continuing with Dr. Jyoti's thoughts and the panel's thoughts, that it's mostly the clinical examination and an imaging and video recording your cases, because later on you can actually find out the missed findings that you couldn't identify at the initial thing. So mostly in neuro-ophthalmology, many of the things are just 2 + 2 = 4, like these cases of ptosis, hypo and exotropia, pupil involvement. So we know it's third now palsy. Similarly, diplopia in outward gaze, we know it's sixth nerve, and a head tilt with an inferior oblique overaction, we know it's fourth nerve. But there are certain situations when the eye movements and the cranial nerve pathologies are not correlating, and that's when you have to think that there's something different that's happening, and you have to kind of go into depth, and at the initial thing, if you do not understand, revisit your videos, because I'm going into the pathways above these nucleus. There is the supranuclear pathways, the internuclear pathways, because we only concentrate about the nuclear and the vesicular down that, but there are a lot of connections. Can't explain in the 7 minutes, but it's important for us to know all the pathways for the pursuits and the saccades, both for the horizontal as well as the vertical eye movements. And I think I'll skip this video, which Jyoti has already told the internuclear ophthalmoplegia. You just note the abducting nystagmus that you can see. So on the right eye, you see the abducting nystagmus, and the left eye, the adduction deficit. So this is a case of left internuclear ophthalmoplegia. Many of the times the imaging may not pick up anything, but then it is the clinical sign itself is enough, because these lesions are very, very pinpoint lesions which may not be actually evident on an MRI. So a contrast and if you tell them this is the area that I want to focus, the radiologist will be able to locate. This is another case with a vertical gaze palsy. Lot of other skew movement, deviation and other things also. And this is another patient. Jyoti also told about the vertical movements. You can also see that Collier sign, the lid retraction that is there. So this is a case of combined horizontal and vertical gaze palsy when the disease spills over the entire midbrain. Okay, and this is another child with dengue encephalitis. Here I want to demonstrate the convergence retraction nystagmus. So the same in continuation with Jyoti's talk. So you can see when you ask the patient to look up, you can see the eye is converging, and you're getting that conversion and the retraction nystagmus. So again, this imaging, you can see the lesions around the medulla-mammillary body and the thalamus. So when you are requesting the MRI, it's better the ophthalmologists don't request the MRI, but you put in your findings to the neurologist, and if they want any additional finding, they can add other things, particularly in children, because we don't want to repeat the investigations again and again. So you tell, this is the focus based on the eye findings, this is the area I'm suspecting, and based on that, they can ask a particular imaging. This is another child, known case of SLE, kidney affected, complained with a difficulty in near vision. Okay, so that is when I'm doing the RAF rule, and for the conversions, it is normal. She's not having any difficulty. But when I put on the reduced Snellen's chart, that is the test which you use for the accommodation insufficiency, you can see that this is where she has the blur point. And so that is reduced, and it's a very nice device, very cheap, and gives you objective values. So here, as I add her the plus lenses, you can see that the near point is coming back to her normal age. Okay, and she was like in her high school, and it was getting difficult for reading. So I have prescribed her reading correction till these bleeds and all. She was put on steroids, and later she recovered. But during the interim period, I have given her the plus lenses. Many of the time, if the convergence is also affected, then you kind of give prisms as well. This is the Yeah, so this is her imaging. As you see here, microbleeds is all that is described. At the end, like you can see that there are multiple microbleeds in many parts of the brain, and our finding will actually sometimes clinch the diagnosis as to where these points are. And this was our intern who started complaining of sudden onset of double vision, and he had a cross diplopia. So he actually had a kind of small ESO, but with a cross diplopia. So that is the thing when you have to think it's not a lateral rectus paresis, but we are dealing with a divergence insufficiency, because in a 6-nerve paresis you don't get a cross diplopia, but you are here getting a cross diplopia, and it was getting neutralized with the 6-diopter prism. And since he was also a myope and it was only 6 diopters, he was I think -4 or so. So for him I have just given a prism, like decentered the lenses to give a prism effect. So he was happy with that, and also working in the department. So again, it's very important, like we cannot see all these cases as a random squint case or something. A little higher order thinking is required when your findings are not fitting into one box. So to conclude, understanding the complex movement disorders, basically what it does is it helps us in localizing the lesion in the brain, because everything, the radiology, I mean, it is so difficult for us who know the symptoms to identify where the lesion is, and the neurologist, the radiologist will have no clue as to what to describe. So it is for us to read the imaging finding, and the management is conservative. It's mainly glasses, prisms, and Jyoti told about the medical treatment for the nystagmus. Usually these are with association with the neurologist. Baclofen is the commonest drug that is used for the nystagmus associated with these conditions. And of course, as ophthalmologists, we can give prisms and glasses. Botox can also be used in temporary cases. Mostly in the, I think if there are, I mean, no students here, so I think it's mostly us. But the book by David Z is an extremely nice book to read about this neurology of eye movements. Thank you so much.
Thank you. I want to ask any question?
From the audience as well? Okay, thank you, Dr. Chinmay. That was a wonderful presentation. So with that, we conclude the session. I would like to congratulate our chairperson, Dr. Sanjay Chaudhary, our convener, Dr. Shruti, and myself, Dr. Priyambada, who moderated the session well. And we thank all the learned speakers for enlightening all of us with so much enlightening that, I think we would not fear neuro-ophthalmology so much, all of us, right? And also the patient listening of all the audience. Thank you so much, everyone. I would like to request our chairperson to please give the concluding remarks.
It was really nice to listen from learned speakers on such a confusing topic to most of the ophthalmologists. During MS examination, if you get a case of neuro-ophthalmology, we all get scared. After listening to all these from learned speakers, we were really happy. It would have been happier if some students were there. Anyway, I thank everybody, everyone present in this hall for attending this session. Thank you. Okay.